Good afternoon. I'm Chris Fanta. It's my pleasure to welcome you to Asthma Grand Rounds and to what promises to be a very interesting discussion about chronic rhinosinusitis and nasal polyps by two renowned experts in the field. And before I introduce our speakers, I just have a quick announcement. I welcome those of you who are joining us by live webcasting. And if you'd like to submit a question that we'll pose to our speakers at the end, just text your question to the number shown here on the screen, 617-513-6043. You'll need to write that down. And then for CME credit, just send me your name, your medical degree, and your email address, cfanta@partners.org, and we'll make sure that Harvard Medical School awards it. So for our program, or one other thing, I'm sorry, because this is the last session of this 2018-2019 Asthma Grand Round series, I have a chance to share with you our program coming up for next year, and it's an exciting program, so I just thought I'd highlight what's coming soon. We're going to have a presentation by Dr. Weiss about a multi-omics approach to lung development and the origin of asthma. Stephanie Shore is going to talk to us about insights from animal models about obesity and asthma. Bernard Kinane will come and talk to us about exercise and asthma. We'll have a case-based panel discussion about management of severe asthma. And we'll have a pro-con debate on this controversial topic. There is no longer a role for inhaled steroids alone in the treatment of persistent asthma. So it sounds like a fun year ahead, and look forward to these presentations. So for this morning, I'm going to introduce our speakers in the order that they'll be presenting two talks, and then join us for question and answers taken together. Dr. Neil Bhattacharyya is a member of the Division of Otolaryngology here at Brigham and Women's Hospital and professor of surgery at Harvard Medical School. And Dr. Daniel Hamilos is a member of the Allergy and Immunology Division at Massachusetts General Hospital and has been a member, an important contributing member to Partners Asthma Center for many years. Both are recognized as top doctors, best of Boston in the Boston Magazine, and together have more than 40 years experience in the treatment of these diseases. So we're delighted to have them speak to us today, beginning with Dr. Neil Bhattacharyya. We're going to talk about the surgical and medical management of chronic rhinosinusitis and nasal polyps. Thanks, Neil.
Is there a laser pointer up here, Chris?
Do you want to use the...
Yeah, I can use this. That's great. Thank you very much, Chris. I'm delighted to be here. It's now with the epic age, we just don't have enough time to get together and just see some familiar faces and reconnect visually and in the same room. And I'm glad we get to connect with some of the people across town at MGH. I'm delighted to be here. Delighted to share the podium with a great colleague of mine, Dan Hamilos. But I'll just dive right in. And I think both Dan and I could each fill an hour, maybe more, maybe put you to sleep with what we have to talk about. But I'm going to try to talk about maybe a little bit of epidemiology of this from the ENT standpoint. I think this is a great opportunity to share some multidisciplinary perspectives on chronic sinusitis and asthma. I don't say rhinosinusitis, it just takes so long. So I'll just say chronic sinusitis often. And share our thoughts from the ENT side of the moat. So how do I go forward? Just I'll hit this arrow, I guess. Okay. I'm not going to bore you with a lot of epidemiology here, but, I think you're all familiar with roughly, depending on who you believe, what the referral nature is, somewhere between a 10 and 15 or 10 and 16% prevalence of asthma, lifetime prevalence in the general population. CRS is somewhat lower. It's 4.9. There are a lot of data out there that it's 12 or 16%. That's wrong. That's based on a faulty questionnaire that was elaborated by the NIH in the sense that actually it's a faulty questionnaire. It was misinterpreted. About 5% of the general population has a lifetime prevalence of chronic sinusitis. But of course, the intersection of those two would be something like, 1% or something along those lines. But we all know that there's a significant overlap or comorbidity between asthma and chronic sinusitis. So that's what I'd like to focus on a little bit here. So on the left-hand side here, if you look at from what we see in patients coming into the ENT clinic, if you have patients with SNP as without SANS or without polyps, somewhere around 20% will have some form of asthma. If you take the patients with polyps, it's getting close to almost 50%. And some of the data from down south where AFRS, allergic fungal rhinosinusitis, is really prevalent, you can get upwards of 2/3 of the patients, maybe even 3/4, have some form of asthma. I'm not going to spend a lot of time talking about asthma as a child coming into adult. Maybe Dan will talk about this versus late onset asthma. I'm going to use it as a surgeon would very crudely and just talk about asthma / reactive airway disease / symptoms that need to be managed in conjunction with their sinusitis. So these are all in referral populations on the left. So we wanted to take a look at, is this really true kind of in a larger population? So we tapped one of the national databases looking at some 11,000, almost 12,000 patients. This is now, again, patient-reported concurrence. So 50 of the patients with asthma. So before I'm telling you of the patients with CRS, how many have asthma, now I'm going, of the asthma patients, how many have some form of sinusitis? And you can see there's a pretty good component, 20% with sinusitis and asthma, 20% with sinusitis, asthma, and atopy. And, this group is actually about double the asthma / hay fever group, which I think a lot of people in general, primary care physicians, for example, and even we associate more allergy with asthma, but in fact, CRS is probably more associated. So, real briefly, 50% of the severe asthma patients, depending on how you stratify them, will have some component of CRS, and then a third with the non-severe groups will have it. So it's certainly something worth looking at in both my CRS patients for asthma, and I would assume in your asthma patients, particularly the severe group, do they have a sinusitis comorbidity? And this goes even deeper. The asthma severity does correlate strongly with worsening CT evidence of disease, how much volumetric disease, and we'll cover that in a second. Interestingly, acute exacerbations of CRS are really strongly linked to poor asthma control. There's some very interesting prospective longitudinal studies in our literature that show that patients will often have a CRS exacerbation that goes somewhat undiagnosed either by the patient or their physicians, and then they end up with an asthma exacerbation and then need steroids. So that is something to query our patients about in terms of the linkage between acute exacerbations and asthma. And this, again, seems to be independent of the allergic disease in a significant number of patients. Interestingly, it's not just always purely cross-sectional or simultaneous. There was a really nice study done by a colleague of mine, Amin Javer, in Canada, who looked at patients who entered the study. This was their national healthcare database study. Patients who entered the study and followed for 12 years. At baseline, they could have either no CRS or CRS, but they could not have asthma at baseline, and they could not be on asthma medications. So asthma naive, so to speak. And they followed these patients, and over the course of 12 years, the risk in that time frame was of developing asthma. Again, we could call it reactive airway disease, asthma-like symptoms, asthma-like syndrome, was 6%. So no asthma, had CRS, 6% developed that. But if you looked at the patients who had CRS, it was double that. It was 12% of those asthma-naive patients developing asthma when they had some baseline CRS. And interestingly, and I noticed one of your talks was asthma and obesity coming up. And we actually, digress for a second, we did a study also looking at the obesity prevalence and the severity of disease in our CRS patients. And in the eosinophilic subgroup, there is a strong correlation between increasing obesity and the severity of CRS. So I may come to that talk. So this is what we notice, and I'm sure you're seeing some of these patients that I alluded to, and these are these late onset asthmatic or asthma-like syndrome patients who really never had asthma as a child, but all of a sudden at age 30, 40, 50, even later, come down with very often asthma and CRS and nasal polyps, steroid dependent or required for management, and often have a high correlation with obesity. So I think one of the things that we miss in otolaryngology in terms of CRS, and I think this would be, helpful to you as colleagues, is how are we going to, so we suspect asthma, we suspect chronic sinusitis in our asthma patients, how are we going to make the diagnosis? Does everybody have to be seen by ENT? Can I make it myself? Is it a clinical diagnosis, et cetera? So Dan and I served on a guideline panel about 10 years ago. That's since been revised, but the diagnostic criteria that we use have remained the same. And I think you're very familiar with this, so I won't belabor it. But, we diagnose CRS when there are 12 plus weeks of 2 or more of these kind of patient-reported symptoms, what I've termed the cardinal symptoms of CRS, mucopurulent drainage, nasal obstruction or congestion, facial pain, pressure fullness, and or dysosmia. So these are the subjective criteria, and then you want to correlate that with one or more of somewhat objective criteria that on exam you see purulent mucus in the middle meatus, and or nasal polyps, and or you obtain a CT scan showing inflammation. Typically, even in otolaryngology, we rely on the CT scan as a gold standard, and I'll talk a little bit about that. What's the value of nasal endoscopy? I'll just share that with you. So could we get a CT scan on everybody? That's easy enough to do. It's a little on the expensive side. Maybe it's quicker than getting an appointment with otolaryngology. But should we do that? The answer is probably not, because as it turns out, these subjective symptoms, even if you have 2 or more, the positive predictive value, or the likelihood that they're going to have CRS is actually relatively small. So we can enhance that kind of predictive value and analysis with the endoscopy. And we did a study looking at, I think, 120, 130 patients in groups with and without nasal endoscopy. And we showed that, with nasal endoscopy, particularly looking for the purulence in the middle meatus and or nasal polyps, we can really increase the likelihood ratios for CRS based on the CT over symptoms alone. So bottom line, symptoms are poor guide. You're going to require at some point for the CRS diagnosis either a CT or a nasal endoscopy, or sometimes both. So if you don't do nasal endoscopy, I know Dan does nasal endoscopy very thoroughly in his office. If you don't do nasal endoscopy yourself, you're going to rely on the CT scan. So you don't need to memorize this. The point is, what is a positive CT scan? One man's mucosal thickening is another woman's normal sinus lining. So we, in otolaryngology, use a staging system for this. This is the most widely used one. You can tally up the different sinuses on the CT scan and score them. OMC stands for osteomeatal complex. I'll cover that in a second. And the scores can range from 0 to 24. I will share with you some other research that we did. So looking at that CT scan, what's a positive scan like? Is one sinus opacified enough to be a positive scan? Do you need multiple sinuses? Do you need bilaterality? So again, we looked at a large number of patients with and without CRS. The control group was patients undergoing, I think, neurosurgical procedures and no symptoms of sinus disease. And I'll just move a little forward in the interest of time. Depending on what the base rate prevalence is, you can establish some criteria, sensitivity, specificity, and positive and negative predictive values for the CT scan. And as it turns out, as I alluded to, the base rate prevalence is important. If you look at that score, which is again 0 to 24, generally we consider anything 0 to 1 as normal. Incidental findings, I would even say 2 to 3 is normal. Is that? There you go. Yeah. 2 to 3 would be normal, and 4, do you want to take a look? No, okay. Would be borderline. You'd probably have to do some patient-centered decision-making. And generally, if you have a score of 4 or more, that is very good predictive value for actually the presence of chronic sinusitis. Now, I don't expect you to pull up every scan and score them. It's probably not a good use of your time. So I'll come back to that in a second. So again, we need to I think we've done a relatively poor job on our side of the fence in terms of selectively using CT scans and making an accurate diagnosis of CRS. So the question is, when would you want to perhaps order CT scans for your asthma patients manifesting one or more of those cardinal symptoms? I think obviously in the severe asthma patients, you're well familiar with that already. I won't belabor that. Patients who are just, requiring multiple rounds of oral steroids and or multiple inhalers, difficult to control based on their ACT scores. But from our standpoint, or a patient in your office who maybe has reasonably well-controlled asthma but complains of dysosmia, purulent nasal discharge on a regular basis, significant nasal obstruction, congestion, and or, of course, if you see polyps, and you guys are actually, you're pretty good at it. I've seen many of you diagnose polyps, the presence of polyps or polypoid degeneration just based on the otoscope exam in the nose. So kudos to you in that regard. I would point out that the one cardinal symptom, this facial pain, headache, pressure, is actually a negative predictor. The odds ratio is below 1. So patients who come in with no dysosmia, no purulent discharge, you don't see polyps in their breathing is, it's okay. But they say, I have this intense facial pressure every day. They are unlikely to have a positive CT scan. Unfortunately, sometimes they have to order the scan for reassurance purposes, but they actually are unlikely to have it if that's the sole cardinal symptom they manifest. So what can you look for on the radiology report, since you're probably not going to pull up every scan unless you have some free time on your hands? I would say if you take a quick glance at the CT report, and I think these are pretty strong predictors of an indication to either treat medically for the sinusitis component, if you're comfortable, probably you are, I'm sure, with that, versus having one of us take a look. If you look for kind of keywords, pansinusitis, suggestive of polyposis. If you do have complete opacification of a single sinus, that's particularly interesting and predictive. I'll talk about the osteometal complex, but the radiologist is supposed to comment in general on the status of the OMC, patent or not patent. If you see hyperdensity, high attenuation secretions, mucin, sometimes they'll call it allergic mucin, this is very highly suggestive of significant sinusitis or high predictive value for radiographic diagnosis of CRS. Or if you see mucosal thickening in 2 or more sinuses, if the comment is both the maxillary and the ethmoids, or bilateral maxillary sinus disease. And lastly, sometimes they'll comment on hyperostosis. So these are some really good watchwords in the radiology report that would be very suggestive of true sinusitis, chronic sinusitis occurring in your asthma patients. So it wouldn't be a surgical talk without a little show and tell, or a talk from a surgeon. So we have the osteometal complex is a somewhat vague term, but it's kind of in this area, bordered laterally by the orbit. This is the uncinate process. This is the maxillary infundibulum, where the maxillary sinus drains. And this kind of complex from the maxillary sinus opening to the middle turbinate up to the anterior ethmoids is the osteometal complex. It's where basically, 3 or so sinuses drain in their confluence, because the frontal will come down into the osteometal complex as well. The other structures I'm sure you're familiar with already. So this is what we would see typically in patients who have difficult to control asthma and concurrent sinusitis, or especially this kind of adult onset or late onset asthma with polyposis with eosinophilia group. This is obvious. You see a scan like this, they got pansinusitis. If you look carefully, you can see this kind of stippling in the ethmoid and maxillary region, and you can see that you don't see these structures, the septations, and even the middle turbinate is somewhat nebulous. This is a patient I saw who had almost 2.5 years of severe asthma. Western Mass just kept getting 3 to 4 rounds of steroids every year, and ultimately told her physician, I can't smell, got a scan, and then this turns out to be a case of pretty substantial allergic fungal sinusitis. No history of asthma before surgery. This was a successful case for us. Did an endoscopic sinus surgery, a little back-end medical management with my allergy, immunology colleagues, and her asthma she's off all of her inhalers. Doesn't happen every time, but it did in this one. This is a case of unilateral sinusitis, and again, if you look carefully here, you'll see these areas of hyperdensity, and it looks like a little string of a concretion here. That's just very, very high attenuation secretions. Looking at the bone, at the soft tissue window, you can see this is, again, very suggestive of allergic fungal sinusitis, and indeed that's what we confirmed. Did her surgery, very straightforward case, and she's now 2 years out and asthma symptom free. She did also not have asthma. You don't need to have that severe disease on the scan to have pretty substantial contribution to worsening or exacerbations or difficult to control asthma. Even this, where the radiology report will say they'll often call this mild mucosal thickening, but the key here is it's really circumferential. It's just not at the base of the sinus. And again, you see this dense opacification of the ethmoid labyrinth on both sides. And if you look really carefully at the soft tissue windows, I think you can appreciate there's this whitish outline right here and a little bit down here. And this patient also had that very thick and inspissated allergic mucin at the time of surgery. And then lastly, I'll just comment on the sphenoid sinus. This seems to be a sinus when it's opacified or completely opacified that seems to contribute a lot to asthma exacerbations. I'm not sure why that is, except the sphenoid sinus is very posteriorly located. It's the one sinus that really drains directly posteriorly into the back of the throat. And I don't know whether patients are aspirating those secretions or there's something along those lines, but it's definitely a more symptomatic sinus as it relates to the asthma component. And here you can see this hyperdensity in the right sphenoid sinus. Real briefly, during surgery, push the superior turbinate over and multiple polyps in the sphenoethmoid recess, take those down, and when enter the sinus, we see this blackish, tannish material that comes out like, it looks like oatmeal you left out on the counter overnight and came back, and it's like a sludge that we have to it's actually very tedious to remove. And this is pretty common in the CRS with asthma patients. I'm going to move along pretty quickly because I don't want to take up Dan's time, but I do want to focus that, we're addressing multiple things when we try to manage the CRS in the setting of asthma. Of course, we want to improve sinonasal symptoms, just kind of sinonasal specific quality of life, asthma specific quality of life, and then hopefully when we do surgery or treat medically, we're going to make some headway in terms of some objective measures that we would like to see. I'm going to skip this. We do well in terms of symptom management. This is looking at 340 cases with 1 year of follow-up. We do quite well in terms of the sinonasal symptom management with surgery. But how do we do when we're faced with the comorbidity of asthma? This is not a great meta-analysis. It's in our literature, so it's not going to be a great meta-analysis, but they looked at just in general kind of dichotomous outcomes in terms of how did patients do after sinus surgery when they had greater than mild, so moderate or severe asthma based on the asthma control score and various other things. In this, we do pretty well in terms of the exacerbations. As I told you, looking forward, from the forward standpoint, exacerbations are very strongly tied to worsening asthma or difficult to manage asthma. When we take that out of the picture from a sinus standpoint, we do definitely offer some improvement. We're not going to get people off inhaled corticosteroids in general. Sometimes we do, as I talked about in a few of those lucky cases. They're still going to have some component of asthma that's going to need your help in managing. What about objective measures? If you look at the PFT studies, again, they start doing better meta-analyses. Things drop off because of heterogeneity and differences in measures. But in general, with surgery, we do have some positive impact with some of the parameters that are important to the objective assessment of the asthma. So I just want to leave it out there. We're kind of targeting hopefully multiple things. It's not just the asthma in itself. In the interest of time, I'll just end pretty much here. I just hope I've touched upon some of the associations between asthma and CRS that you can reflect on in your own patient population. Basic screening can be accomplished in the office with the cardinal symptoms. If you have time to look in depth at the CT, great. If not, the report can be very helpful. Line of surgery does have a role, I think, in the management of particularly the more severe, moderate to severe asthma patients that you face. And then lastly, I'll leave with the fact that I'm very grateful for the collaboration I've had with so many of you in the audience over 20 years. I didn't think I was going to get to that. 20 years, my colleagues from pulmonary medicine, allergy and immunology, and not to forget anesthesiology, because some of these patients are difficult to put to sleep, difficult to wake up, difficult to manage perioperatively. And I appreciate all the attention you've given our patients perioperatively. Thank you. Now I'm turning it over to Dan because just like when surgery fails, I turn it over to Dan.
And of those 40 plus years of experience, I carry the majority, so Dr. Bhattacharyya need not apologize for that. I'm much older than he is. Let's hope I can find my lecture here. Is it possible for that to be loaded for me? Here we go. Okay. Well, it's indeed a pleasure for me to be here, and I've really enjoyed working with Chris and the Partners Asthma Center over the past 15 years, and so it's a pleasure to be here with you today. I had a few disclosures. They don't really apply or pertain to anything we're going to talk about. So we've known for a long time that chronic rhinosinusitis is a spectrum of illness, and for some of us who just like to sit around and think about this and ponder it a lot, it's always been a challenge to try to figure out what's going on. But this article that I wrote for the JACI in 2000, I mentioned that I thought there was a spectrum of illness with infection being on one end and non-infectious inflammation, things like eosinophilic inflammation, being on the other end. When I was lucky enough to co-chair a committee that helped to define, update the definitions of chronic rhinosinusitis in 2004 with Eli Melzer, we had experts from around the world, and we came up with this diagram, and you can see the key things are that we thought that the distinction between CRS without polyps and CRS with polyps was quite important, and that underneath either of those we had multiple different subtypes of CRS. Within the CRS without polyp group, we acknowledged that there really wasn't much known, and this was a very heterogeneous group, whereas with the polyps, at least we understood that there was an eosinophilic type associated with fungal involvement, that being allergic fungal rhinosinusitis. We also acknowledged there were many cases without fungal hyphae, and those turn out to be very important too, as I'll mention in just a minute. Now, Dr. Bhattacharyya has already talked about the complexity of sinus anatomy, and so I won't belabor the point, but only to say that anyone who's trying to be medically deal with patients with this kind of problem needs to appreciate the importance of sinus drainage and osteal obstruction. And if you have that, then patients are going to have persistent problems. This was after we did the definitions paper, my attempt to look through data that we had at Mass General and parse it out to see whether we saw differences in the clinical presentation of people who had CRS without polyps versus CRS with polyps. And you can see in this sort of, this is sort of like meant to be like a matrix of different factors, and things that are on the lower right-hand side are things that were statistically more likely to occur in people who had polyps, as opposed to the things that are in the upper left. And many of these are things that Neil has already talked about, like the asthma and the eosinophilia and osmia, which are very strongly associated with polyp disease, along with FRS as well. So ultimately, there's a matrix of factors, and the fact is that we still are just really trying to unravel these, and there's many other things going on, as I listed on this slide, that are still in the process of being unraveled. Two things that I think are really worth mentioning, because they sort of are the bane of my existence, because first of all, we're dealing with people who have recurring infections, and so there are many issues going on that we think in the epithelium that could be responsible for this, including defects in innate immunity, and people have referred to biofilm as being an important contributive factor for persistent disease, and even disturbances of the microbiome, which because we have an expert in that in the audience, a group over here that discussed microbiome in chronic rhinosinusitis recently. On the other hand, we know that we have things in the epithelium that promote eosinophilia that are independent of allergic status, and Neil mentioned that the severity of sinus disease in relationship to asthma is really independent of allergy, and so that really does sort of beg the question about these other factors like epithelial-derived cytokines, IL-33, IL-25, TSLP, and what role they play as drivers of inflammation. So ultimately, this is a slide that sort of summarizes what we consider to be drivers of the inflammatory process in CRS. Getting back to more clinical, because ultimately I have to go to clinic. I'm due to go over there this afternoon, as a matter of fact, and so we have to have some sort of a starting point for how we categorize patients. And this is my diagram for it, and I know that Neil had a different sort of diagram based on Venn diagram of asthma and so forth, but this is one that's really focused on CRS. And if you look at the literature, they will tell you that CRS without polyps is the more common. They say it's something like 70% of all cases, whereas polyps are about 30%. But as Neil said, in his clinic as well as in my clinic, polyps are much more prevalent because we tend to see the really severe cases more often. And then we can subdivide it even further. We have experts in the audience on AERD, aspirin exacerbated respiratory disease. That's really mostly in the category of what I would call eosinophilic mucin rhinosinusitis, a very important subgroup that I'll talk about in a minute. Neil mentioned allergic fungal. That's really a small percentage of the total here, and it's a smaller than EMRS percentage of the polyp group. And then we have these other clinical ones that we don't really have time to discuss, like cystic fibrosis and ciliary dysmotility and so forth. So we have to have a framework in the clinic for how we're going to evaluate this and parse it all. And this is sort of what I came up with. And I do want to emphasize that this is really an iterative process, so it's not necessarily something that I know right off the bat what's going on. In fact, I need to talk to the patient, get the history, review a sinus CT scan, consider allergic and contributive factors as well as asthma, look for infection. This is also often very important to try to figure out what's going on. Initiate a treatment program and then reevaluate based on the response to that. So this is a complex process and sometimes takes a few months to really sort it out. So now I want to just talk a little bit about different phenotypes that I think I actually understand in CRS. This is an example of CRS without polyps, and the images are a little bit small, but I think you can really appreciate in this pre versus post sinus CT scan that this is a patient who had all the symptoms of chronic rhinosinusitis, came in for an allergy evaluation. She actually had no allergies, but she had a very abnormal CT with nearly opacified maxillary sinuses and obstructed osteomeatal units on both sides. She was treated aggressively with prednisone plus an antibiotic, and this was a protocol that we adopted at Washington University many years ago that we call intensive medical treatment, namely antibiotics for about 4 weeks along with prednisone for 8 to 10 days. And you can see this patient dramatically improved, and she stayed well for many months thereafter. On the other hand, we found out that if people who have polyps at baseline, namely the one on the right, tended not to respond so well. They got somewhat better after the treatment, probably because of the prednisone, but their symptoms relapsed very quickly. We also found that people who had had prior surgery were more likely to relapse. Now, so what is my job in a case of CRS without polyps? My job, I feel, first off, is to really evaluate sinus patency, and if there is sinus blockage, eradicate infection. We could have a long discussion. In fact, I had a debate with Klaus Bockert at the Academy meeting a couple of years ago about the role of antibiotics in CRS. And, most people are just have this sort of gut reaction. They don't want to use antibiotics unless they really have to. So my role as pro in that argument, I was automatically, handicapped, I would say, in the argument because most people in the audience were against use of antibiotics. But the fact of the matter is, certainly in my experience, infection is important. And when you have obstructed sinus ostia, there are many instances I can show you, actual clinical patients where treatment with antibiotics plus prednisone has really helped. Now, we could argue about exactly when that should be done and what you should do first before that with saline rinses and steroids and so forth. And that's a long discussion, but just keep in mind that infection is still on the table. We also need to address comorbidities and think about immune deficiency. But ultimately, if I fail, then I'm going to refer to Dr. Bhattacharyya for an ENT evaluation. Part of my job also, after a patient has surgery, is to help in the medical management postoperatively. And one thing that I found is really, really helpful is getting sinus cultures. There are a couple ways to do it. This one is this aspiration device, this Lucan's trap, is really a nice device. On the other hand, you can use something simple as a sterile cotton tip swab and go in rhinoscopically and get a nice culture. And this is really, really valuable in the management of patients. On the other hand, let's switch gears and talk about polyps. So this is, again, you can see, you recognize the picture in the middle of somebody who has advanced bilateral polyposis. Notice that the patients had prior surgery, so the osteomeatal units are wide open, so this really isn't any problem with that, but yet the disease is still very active. If you look endoscopically, you see polyps in the ethmoid region on the top there. If you take the patient to surgery, you can pull out very large polyps in some instances. And ultimately, through a number of studies that my group did over the past 25 years or so, we know that this is a very Th2 biased inflammatory response with lots of eosinophils in most cases, and Th2 cytokines, including IL-5 and IL-13. And remember those because those are quite important. So what I view as my job in this condition is to, first of all, if I see polyps or I have the CT and other evidence that polyps already are present, my job is, number one, to try to stabilize the disease medically, which you can attempt to do with systemic steroids, and then also to devise the best possible strategy for use of topical steroids, because this is a mainstay of ongoing treatment. Of course, we need to address the allergic comorbidities and asthma, and consider whether this is one of these complicated polyp patients who has AERD, EMRS, or AFRS. Because in the worst cases, we're going to need to consider biologic treatment. Now, this is one example of a complicated polyp patient. This, you recognize this is allergic fungal rhinosinusitis with the features that Neil Bhattacharyya already showed, including the pan-opacified sinuses with marked hyperdensities. The mucus that was pulled out of the sinus, he described it as like dried oatmeal. I'm not sure if I would call this dried oatmeal. It looks grosser than that to me, but you get the idea. And I'm sorry if anybody's eating lunch right now. This mucus should contain fungal hyphae. That's a key criteria for this disease. Usually that doesn't require immunofluorescence. Usually it's done just by the GMS stain. If you look at you have to make sure the tissue doesn't have fungal organisms in it, because that would not be allergic fungal, that would be invasive fungal disease. So this is fungus in the mucus only, and it's associated with the eosinophils that are in the mucus. These are just some other examples, and the other point I wanted to make, if you look at this lower right panel, that's an MRI, and you have to take my word for it. The corresponding CT was a completely opacified left frontal, but on the MRI, it looks completely empty. That's often a board question about AFRS, that the MRI on a T2 weighted image, the MRI can look completely clear, even though the sinus is completely opacified with AFRS. So what's my job in this case? Well, first of all, I need to be suspicious of it, and I would be suspicious if I saw opacified sinuses with hyperdensities. I would be suspicious, too, if this was unilateral, and Neil was very nice to supply a case that was unilateral AFRS. I used to think that would be rare, but that's not so rare. It's actually not that uncommon. These people can have very aggressive inflammation, and they get bony erosions as a result. They tend to be younger. They all have fungal allergy. They tend to live in endemic areas, such as in the southern part of the United States, Florida, Louisiana, Texas, and they tend to also be African American. We don't know exactly why, but even in the very earliest studies I did of nasal polyps, when we looked at polyps from African American patients, they were more eosinophilic, just more impressive. I used to make slides out of them because they just were so intensely eosinophilic. So this is an allergic disease. So the first thing we need to do is establish the diagnosis, and usually that requires surgery and then ruling out invasive fungal disease. And once that's established, then we initiate both systemic and topical steroid treatment. On the other hand, there's many cases that sort of look like AFRS, but they're really not AFRS. They are this entity. This is called eosinophilic mucin rhinosinusitis. Now, this is a contribution from a great friend of mine, Beryl Ferguson, who unfortunately passed away a couple years ago. She and I went all the way back to residency program together at Duke. But she described this paper about something that looked exactly like AFRS radiographically and clinically, except that it wasn't it because she couldn't find any fungi. You see the hyperdensities on the CT here, for example. This is an example of one that everyone in this audience has seen, this condition. This is AERD, and AERD is essentially eosinophilic mucin rhinosinusitis. Now, the two are not exactly the same because there are cases of EMRS that do not have aspirin sensitivity, but nonetheless, there's a very high overlap between these. And when you look endoscopically, my pictures here are not as nice as Neil's because he's got more expensive equipment. But this is polypoid disease in the sinuses. It's very edematous, just really edematous tissue, and it's classic for the patients with aspirin sensitivity. What's my job in this? Well, the first thing is, of course, I have to be suspicious that this could be AFRS and make sure that it isn't. So that ultimately is probably going to mean referring to an ENT surgeon to establish the diagnosis. But just in terms of general statistics here, if you have somebody with bilateral disease, very extensive sinus disease, without bony erosion, by the way, bony erosion is not something that you would expect in this. If they're negative for allergy testing to fungi, and they may be completely negative on everything, which is amazing, then this is more likely to be EMRS. These people almost always have asthma, they have eosinophilia, and as I mentioned, they have AERD as well. So what we need to do is we really need to establish the diagnosis, rule out AFRS, rule out invasive fungal disease, and then once we've done that, then we can initiate systemic steroids and topical steroids, consider aspirin desensitization, and even consider biologics for the underlying asthma. And the reason I don't say consider biologics for sinus disease, because at least today, June the 7th, 2019, there are no biologics approved for polyps. Now, if you wait a week, that may be different. This is a study that showed this is actually part of B.J. Ferguson's paper that shows everything that I mentioned. There's an age difference between EMRS and AFRS. There is a difference in terms of unilateral disease versus bilateral disease, the difference in asthma, a difference in aspirin sensitivity, even a difference in terms of IgE levels. So these are clearly two distinct entities. Now, I mentioned appropriate use of topical steroids, and of course, a lot of you who know me know that we have done for a long time off-label use of budesonide as a topical installation. It's a crazy way that people get in their head positions to do this, but I can just tell you that it works, and I have many, many people that just get so much better with this. It's really changed their life. So it's worth mentioning. It's been published in one nebulization study, and this is just an example at the bottom there of someone before and after this treatment. Now, there's other ways to do it. You can also give steroids intranasally, such as Nasonex, or you can use this new device called the Xhance device, which is a sort of a propelled form of fluticasone that penetrates further up into the sinus cavities and has been shown in this Navigate-2 trial to be an effective way to treat polyps. I also mentioned that these people, if they're aspirin sensitive, they could benefit from aspirin desensitization. And so I do have a group of ENTs that refer to me and right before surgery, and we get them organized so that right after they've had the surgery, we bring them over, make sure their asthma is stable, and then we put them through aspirin desensitization, because in our experience and that of the scripts and many other, I'm sure here too, about 2/3 of these patients actually will stabilize their disease after they are aspirin desensitized. Their sinus disease and their asthma may get better as well. Now, despite all that, there's still many cases that are refractory, and we really don't have time for me to go into them. I wish we did, because they're really interesting cases. And I just wanted to mention that there is this one that I want to coin this term complex polypoid, because these are just really the bane of my career, because these people are coming back over and over with infections that we can document by culture. Their disease is either continuous or repeated exacerbations, and on nasal endoscopy they have polypoid changes in their sinuses, but they don't have classic polyps. And you could argue, well, maybe that's because you're partially treating it, but the fact of the matter is this is a different, these are really difficult patients with a high disease burden and frequent surgeries as well. Now, just a couple mention about asthma and CRS. Obviously, there's a big overlap, and Neil very nicely went through this. There's not really a specific type of CRS that's associated with mild to moderate asthma, but a point that was published in this paper by Ten Brink and colleagues was that the extent of disease on the CT is related to the underlying severity of asthma, such as the level of exhaled nitric oxide, and blood eosinophils. And Neil mentioned this point. So this is an important relationship between asthma and extensive sinus disease. On the other hand, these other subcategories of asthma, such as AERD, severe persistent eosinophilic asthma, and eosinophilic granulomatosis with polyangiitis, are all associated with CRS with nasal polyps, and specifically with EMRS. And that's why EMRS is really such an important clinical entity. What about targeted biologics? I want you all to memorize this slide, which is not my doing. Of course, it would have taken me about 5 months to do this. But you can see certain cytokines here highlighted prominently, like IL-5, IL-13, there's IL-4. So these are cytokines that are important as in terms of drivers of not only systemic Th2 responses, but also local Th2 responses. So it sort of made sense for a long time because the studies we did with the cytokines and polyps went back to 1993. So, I've been waiting for a long time for biologics to come along, and it's really kind of nice to be able to actually say we finally hit pay dirt with these. This is going to be the era of endotyping sinus disease too, and the reason for this is because now we want to be able to say, okay, what are the targets of inflammation that we want to hit? Because we're going to have cytokine blockers of different sorts. So right now we're going to focus on eosinophilic because we really don't have a lot of information about the other endotypes of CRS. We know about them, but we don't know, for example, whether the Th17 is important enough to be a target yet. So what we know about the biologics is that there have been some small proof of concept studies of omalizumab, for example, that was positive in a very small, like 24 patient population study of polyps. Mepolizumab also in a roughly the same number of patients. But then there was a larger trial published in 2017 by the Belgian group with mepolizumab. Notice that they used the high dose of mepolizumab, 750, as opposed to the 100 milligram sub-Q dose that we use for asthma. But this showed a significant effect on polyps and quality of life and objective evidence of disease, so that mepolizumab is another reasonable candidate drug for polyps. What we know the most about is dupilumab, because this is the phase 1/2 trial that I was sort of involved in and am still involved in because there are still papers being published from this study. But this was like a voila study, because the dupilumab effect in terms of reducing nasal polyps was really quite dramatic over 16 weeks. This study met all the primary and secondary endpoints for benefit of dupilumab. Is very well tolerated biologic, as you know, similar to what it is for asthma. And this then set the groundwork for the phase 3 studies, which have now been completed, and preliminary information has now been released on this, that the phase 3 study looks very good as well for dupilumab and polyps. And in about a week, you should hear that this is approved for nasal polyps. Now, the intriguing aspects of dupilumab really are, first of all, and I had a patient in the study who met all these criteria. He had very dramatic disease. I forgot to mention here, but these studies of biologics are all done with people using Nasonex, 2 sprays per nostril twice daily, which is a very big dose of steroids, and yet they still had very severe polyps before they got on the biologic. And what we saw, and what in the study showed, is very dramatic regression of sinus, not only polyp size, but also sinus disease on CT, a dramatic restoration of sense of smell in many cases, improvement in quality of life. And one thing that's really, really intriguing about this is that the magnitude of effect here is about the same as having sinus surgery, which, what does this mean? Well, maybe one of these days we won't need to send people with polyps for sinus surgery. And I'm not trying to put Neil out of business, but I think he's got a lot of other things to do that rather than just keep taking out polyps. So ultimately, in summary, that's the end of the talk, and just want to highlight to you that I have no lack of things to do when it comes to trying to take care of these patients, but I feel like certainly with the emergence of the targeted biologics, there's a role that any allergist immunologist can play in the management of this disease. Thank you.
Can we invite you up for questions and discussion? There's one question that was sent in from the audience watching by webcasting, so I might put that one to you first, and it's a follow-up on this introduction to the role of biologics, and wondering about markers that might identify patients who might benefit. And the question actually asks specifically, using markers of peripheral eosinophilia, allergies, allergic sensitivity, or elevated exhaled NO came to mind. But in those who did not have those markers, would you ever use tissue biopsy and tissue eosinophilia as a predictor of benefit?
Well, I can tell you that up until next week, when dupilumab is approved for polyps, I would have never used a biologic specifically for polyps. At least not. I wouldn't have told somebody that. But we try to get them approved whenever we could because of the underlying asthma. So
About more broadly, just a rhinosinusitis, even without polyposis.
Well, there's no data yet on rhinosinusitis other than polyposis. But you raise an interesting point, and certainly I do have patients, specifically what comes to mind is that complex polypoid group of patients who is in the office all the time with exacerbations and needing prednisone bursts and so forth. And, many instances, and I kind of quickly went over that endotype slide, but if you're watching very closely, you saw that there was 10 different endotypes, and some of the intermediate ones have a mixture of eosinophils and other inflammatory cells. And so eosinophils actually are in a large number of these different endotypes and just in different degrees. So certainly you can make an argument that a biologic that targets eosinophilic inflammation might work in some of those cases, even if they don't have the other classic markers of disease.
So, a comment. So interestingly, in the polyp patients, the problem is they're so obstructed, they often don't have eosinophilic discharge when they blow their nose, when they irrigate. But the non-polyp patients who have true eosinophilic EMRS disease actually will tell you every once in a while they get a clump that looks like a Kirschman spiral or something like that out. Those patients, I think, would be that'll be clinical evidence that a biologic could be used for them. And also with the Zomad aspirator, we did a study where we looked at, we went in between, the middle meatus, the middle turbinate and Lennox wall, and actually just almost a blind, if you will, aspiration of the middle meatal secretions. And about 30% of those patients, we were able to identify a predominance of eosinophils in the secretion. So there may be other ways to, I think you're trying to, what kind of diagnostic criteria, what things would predict the success of a biologic. Right. And I think those are things that we'll probably be looking at now that the biologics are going to be more prevalent.
Thank you both for really nice talks. Dan, you talked about your success with these nasal steroids. So now that there's going to be biologics, how would you decide about whether... Now that there are going to be the biologics, how would you decide about whether you wanted to do this aggressive nasal steroid washing versus a biologic?
So I know you probably all heard that because Dr. Israel has the microphone, but the question is what I decide now in the era of biologics, whether to use the aggressive, like budesonide rinses for sinuses. So in answer to that question, every one of the biologic studies was done on a background of high doses of topical steroids. So I think that is what we have to keep doing. And so my feeling would be, first of all, to try the aggressive topical steroid approach. It doesn't have to be the budesonide. It could be, the Nasonex. It could be the Xhance device. But I would do that first and then see what the response is and then decide whether I needed to move on to the biologic.
I might comment on that. I think the interesting thing about the biologics, and I do think they're going to have a tremendous role here, but and they may put me out of business, which will be fine. But the question here is, I think, twofold. One is, do you give someone a systemic agent, and we can talk about cost as a whole nother matter, to give something a systemic agent for X number of weeks? I mean, the studies are going out 16 weeks, 20,
the
24
dupilumab
weeks.
study is now was 1 year, and the ongoing studies with Fasenra and omalizumab are now 1 year studies.
So I have to believe somewhere down the line when we are playing with the immune system to this degree at this cytokine level, we're going to see some side effects in a certain group population that's been on this long term. it's just generally true for most chemotherapeutic agents, which we're bordering on here. So I would generally prefer a topical agent that has been shown to have very limited absorption, whether it be budesonide or something like, rather, even in high level polyp disease. And then that begs the question, where does surgery come in? Because just like in oncologic surgery, you can take out the whole tumor, whereas for chemotherapy, it's a log kill, right? So upfront surgery versus long-term medical management. Certainly some people are going to need both, the more severe cases. I think that's going to be a very interesting question to hash out, not only for medication safety and long-term use of an immunosuppressive versus cost.
Thanks for great talks, guys. I was interested, of course, in the mirroring of the upper and lower airway and whatnot. And in those patients who we've all qualified for biologics, one or another, who also have upper airway disease, which we're all seeing. In the folks who seem to fail biologics, do you think they fail in the upper airway also? And do those things come in concert? I hear that exacerbations might come in concert, but the failure. And then I was really interested in the sphenoid comment, because that does. Why would the sphenoid sinus more similarly mirror below? Is it just because it drains and you're taking out that aspect of drainage?
I'll adjust the first part of you. Sure. So I have enough experience with biologics in this realm to tell you that there are cases, for instance, in asthma where Xolair, for example, or Fasenra or Nucala have worked beautifully for the asthma, but haven't really impacted the sinuses. Now, I don't have enough experience with dupilumab yet to be able to answer that question, but certainly I have seen a number of them where that was true. Now, there are other cases where both the lower and the upper airway have improved. In fact, one lady who came to me from Yale was on an experimental mepolizumab protocol for years, and her sinus disease really went away. And so, I mean, her asthma and sinus disease both improved. So it happens in different ways. And with dupilumab, we don't know yet what's going to happen.
Yeah, I agree with what Dan said. I think the difference in the upper airway versus the lower airway is that the lower airways they're not, by the time the sinuses get to polyps, the lower areas are still generally reversible disease, depending on how hard you hit them with bronchodilators and or topical steroids or oral steroids. The problem is once obstruction is set in at the drainage level for the sinuses, there's a certain percentage of those patients that even with the oral steroids and or dupilumab are not going to recover. So I think they fail because there's a persistent obstruction, and then there's some evidence that suggests there's osteitis that goes on that dupilumab obviously can't necessarily treat because it's not purely inflammatory osteitis. I should have put up I apologize, I should have put up a sagittal slide for the sphenoid sinus, because the sphenoid sinus being very posterior drains almost against the posterior nasal, up just above the nasopharynx. And I have seen many patients where it is just dribbling straight down the posterior wall. I don't see that for whatever reason from the anteriorly based sinuses.
Is the exit, I don't just know this anatomy, is it straight down?
Pretty much.
So you think that the osteitis and the other stuff you don't get as much because it's an inferior drainage? Maybe that's why it mirrors more? I'm trying to
I think that makes sense.
If there's a sinus that mirrors the lower airways better than others.
Yeah.
If we were going to sample in order to develop tissue-related things,
That's a good question.
that where you do it.
That's a good. I mean, I'd sample where the CT or the endoscopy shows disease. The sphenoid is hard to sample, unfortunately. It's pretty high up and tucked in a nook and a cranny.
Another question. So you talked about the Lund-McKay score. Would it be helpful if our radiologists, when they did facial CTs, gave us a Lund-McKay score?
I've tried that a couple of times. There are so many people reading CT scans, and it's actually the Lund-McKay score has been validated. It's got good intra and inter-rater reliability. I think it would be great. It's there's so many people reading these CT scans. I just have not made a lot of headway in that. And I've taught. That's a very good neuroradiology group here, but then you have the fellows. That most of the fellows reading the scan, they would have to do that. It's just a labor of love, I guess.
Just one comment about that. I would say that that may well turn out to be useful for when you put somebody on a biologic for polyps, because the radiographic disease does improve. But For people who don't have polyps, it's a totally different ballgame because even an isolated obstructed sinus could be a real problem, and that doesn't correlate with like severity of London Mackay score.
Here's a remote question. Is airway remodeling an issue in chronic rhinosinusitis? Long-term permanent tissue changes?
Okay, I'll start. Well, we actually published a paper on airway remodeling in polyps where we looked at deposition of the types of collagen like 1 and 4 that you see in the lower airway as part of subepithelial fibrosis, and we did see that. You do see the subepithelial fibrosis type of airway remodeling, but that's really, I mean, it's sort of like splitting hairs. That's not the type of thing that's going to cause anybody a real problem because usually in polyps, they're still very amenable to treatment. It has been described that people with CRS without polyps actually get a fibrotic-looking appearance, but I think that's also a bit overplayed because when surgery is done, it's not usually a very fibrotic condition. So I guess that's how I would answer it. It's not, to me, it's not necessarily that big of a deal.
I would say the interesting thing about what we see, the changes in the mucosa for CRS, there are so many different phenotypes. Even at the time of surgery, you have these translucent-looking polyps on one end that look, you take them out, they don't even bleed, and you have these very fleshy, smaller polyps that are like rigidly anchored to the bone. And you take them out, and it's spending 10. It takes 2 seconds to take it out, and it takes 10 minutes to stop the bleeding. I don't know whether I think in that the other spectrum where these are very fleshy polyps, I think there has been some remodeling, hypervascularity, remodeling fibrosis, and I think that those are the patients that they're most likely to fail medical management. I think because there's fibrosis, the oral steroids don't get into the mucosa. The topical agents are trying to penetrate a very thick polyp lining. So I think there is some remodeling does occur. I mean, it's crude what I'm describing, but I think there is a change.
I should say that I don't disagree at all with what Neil said because in our very first polyp study, we actually found we had some patients who had sort of fibrotic-looking polyps. They're just not that common, and so I think for the average patient with polyps, it's not that big of a deal.
Could you inject a polyp with steroids?
Yes. So again, so we do a lot of in-office intrapolyp steroid injections. We typically use Aristocort, which is triamcinolone. And I'd say the hit rate, again, depending on the phenotype of the polyp, if it's this very translucent polyp, that we can, I have several patients that come back every 6 months or 9 months or a year and just get 1 or 2 solitary polyps injected, and they're very happy. The fleshy type polyps don't seem to respond.
Great. Well, it's a wonderful time to thank our speakers for a terrific, stimulating, very useful presentation.
Thank you.
Thank you very much.
Thank you.